Good evening, everyone, and welcome to the annual Scarman Centre, a Scarman Lecture. I apologise for the delay. We've had some technical issues behind the scenes, which we're trying to resolve, but we're going to make a start anyway. My name's Henrietta O'Connor. I'm the head of the College of Social Science, Arts and Humanities, and I'm delighted and honoured to have been asked to introduce this evening's event, which is our most important and prestigious public lecture of the year, the Scarman Lecture. It's wonderful to see so many guests joining us online. This is the second time we've held the lecture virtually due to the pandemic. Although we lose something by not meeting each other in person, the online format, when it works, also provides the opportunity to welcome many more of you to the event, if not to Leicester itself. It also means that our audience is wonderfully global this evening, with delegates from more than 25 countries here at the lecture. Since 2008, our Scarman Lectures have featured high-profile guest speakers delivering papers on current issues in criminology, criminal justice, policing and community safety. Younger members of the audience may wonder why this lecture is named as the Scarman Lecture. As many of you will know, the School of Criminology was established in 1987 as the Centre for the Study of Public Disorder, but it was renamed in the early 90s as the Scarman Centre, named after Lord Scarman QC, who was chair of the 1981 Brixton Riots Public Inquiry. Although the school is now known as the School of Criminology, the legacy of the early days endures both in this lecture series and in the approach of the department, which is recognised for its commitment to conducting innovative, groundbreaking research, engaging with practitioners and providing students and staff alike with the opportunity to develop their knowledge, their experience and their understanding of a subject area that remains central to societies throughout the world. Established in 2008, this series has enabled us to welcome many high-profile speakers to Leicester. This evening's event is no exception to that. With our invited experts from the Policing and Prison Service, in tonight's lecture, titled Drugs and the Criminal Justice System in the UK, we debate what works questions in relation to addressing how the criminal justice system responds to the challenges presented by substance use. I'm absolutely delighted to hand over to Dr. Tammy Ayres now, who will welcome you and introduce our speakers. Thank you.
So thank you, Henrietta. Before we make a start, I would like to thank Professor Tila Sanders and Laura Neve for all the work behind the scenes, which has made tonight possible. While I'm thanking people, because I often forget, I would like to thank you all for giving up your evening to attend this year's annual Scarman Lecture, as well as offer a huge thank you to hopefully our two panel members for agreeing to come and talk about the challenges drugs and their use pose for the criminal justice system, its institution and its agents. This includes how the criminal justice system responds to substance use, what works and what should be done moving forward. Before I introduce the topic though, I would first like to introduce myself, go over the format for tonight's lecture before going on to introduce both of our speakers. Hopefully the second speaker will be able to join us and we can resolve the IT issues. So as Henrietta said, I am Dr. Tammy Ayres. I am an associate professor in the School of Criminology here at the University of Leicester. I've been undertaking research on drugs for nearly 20 years, something I don't often admit in public, and I will be chairing tonight's Scarman Lecture. So you will hear from both speakers tonight, hopefully, before we open it up to questions. So if you have any questions for either Jason or Sue, then please post them in the chat at the side of the screen. If you could state your name, the name of the speaker the question is directed at, and then your question, then that would be great. And I will read these out at the end when we come to the discussion part of the Scarman Lecture. For those of you on Twitter, please tweet using hashtag Scarman 2021, which is all one word, which we will add to the chat now for those of you who aren't sure. So now that housekeeping is out of the way, I would like to introduce our two speakers. I will start with Jason Kew, who is having IT issues and who's representing the police tonight, but we do hope will be able to join us. So Jason Kew is a serving Chief Inspector with Thames Valley Violence Reduction Unit and is the lead for drugs and harm reduction. Jason developed the Thames Valley Drug Diversion Scheme, which basically enables everyone found with controlled drugs an assessment of their use, education and harm reduction without the need for arrest, interview nor admission of guilt. Now, this scheme has been a catalyst for emerging health-based drug policy development across the UK, as well as further afield. Jason is a passionate advocate for challenging stigma, diverting people away from the criminal justice system, and recognising the unintentional over-policing and subsequent damage caused by marginalisation and inequality. Now, hopefully Jason will be able to join us, but you can also watch his video on Transform's website, where there are over 50 people across the country who have been calling for reform of the current drug laws. Our other speaker tonight, who is with us, also has extensive experience of working in the criminal justice system. Sue McAllister spent 25 years in the prison service, including as a governor of HMP Gartree, YOI Onley. She has also served in a number of policy roles, including head of the security group. She was also the area manager responsible for prisons in the West Midlands. And after leaving Her Majesty's Prison and Probation Service, Sue became Director General of Northern Ireland Prison Service and is currently the Prison and Probation Ombudsman for England and Wales. In her current role, Sue is responsible for the independent investigation of complaints from people in prison and covers all deaths in custody. This includes prisons, probation, approved premises, and people detained in immigration removal centres. Now, some of the deaths investigated by the Prisons and Probation Ombudsman and Sue's team are related to the use of drugs, and their reports often make recommendations for improvements to policies and practices to prevent future deaths, but also to improve safety across the prison estate. Therefore, tonight's Scarman Lecture focuses on how the criminal justice system responds to the challenges presented by substances and their users. But why are we looking at this tonight? So last year marked 100 years since the Dangerous Drugs Act. This year marks 50 years since the introduction of the Misuse of Drugs Act, and a war was declared on both drugs and their users, and yet very little has changed. There is no denying that the majority of people entering the criminal justice system have used substances, with estimates ranging anything from 60 to 80%, depending on the source being looked at. In fact, those entering the criminal justice system, and particularly prisoners, have a much higher prevalence rate of substance use than community samples, with dependent, problematic or addicted drug users particularly overrepresented in this population. In fact, there's a small group of substance users who find themselves trapped in a revolving door of the criminal justice system, particularly those with the most complex and multifaceted needs, as some of the following statistics illustrate. So of those cautioned or sentenced by the police for possession offences, 30% receive a caution. However, 3% were still being sentenced to immediate custody. Immediate custody rose to just over half for those sentenced for drug trafficking. Over a quarter of men and almost half of women reported entering prison with a drug problem, while even more shockingly, 14% of men and 12% of women actually reported developing a drug problem in prison. Whereas just over a quarter of women and 17% of men said they actually had a problem with alcohol when they arrived in prison. Now, we also know that drug-related deaths are at an all-time high. And according to Release, they have risen 7,000% since 1971, when the Misuse of Drugs Act was first introduced, illustrating the need that something urgent needs to be done. In fact, there were 117 deaths in prison between 2013 and 2018, where the person was known or strongly suspected to have used or possessed psychoactive substances before their death. Many of these would have involved the drug we know as synthetic cannabinoids, or better known on the street as spice. Therefore, the statistics show that substances and their users present a unique challenge to the criminal justice system and its agents, particularly since they also have high rates of self-harm, suicide, mental ill health. They have poorer physical health, higher recidivism and mortality rates when they're compared to non-drug users. Substances in this context are also linked to bullying, violence, deaths and medical emergencies, particularly when we look at them in relation to secure facilities. And this illustrates just some of the contemporary challenges. And while these challenges vary across the UK, and there are differences in Northern Ireland, Wales and Scotland, substances and their use also present similar challenges to all of them across the board. However, many would argue that the criminal justice system is no place for substance users, and the connection and the contention between a medical, public health approach and a punitive law and order criminal justice approach to substances and their users is not a new theme. Instead, this is a reoccurring debate that has been heavily contested but never fully resolved. And this leaves us in the UK, in this instance, for the purposes of tonight, with what has become known as the British system. So the British system of drug control is basically medical control over treatment that operates within a penal framework of both national and international controls that is enforced through the criminal justice system and its agents. Now, for the most part, the criminal justice approach has dominated. And although you see this vary over time, current policy lies with the Home Office. And although this system has introduced several schemes over the years to try and divert substance users out of the criminal justice system and into treatment, these have not always been adequately funded. It's often a postcode lottery of how they operate. They often aren't used effectively, and therefore they've often have been heavily criticised. And this is alongside prohibition, which we know the pitfalls and the criticisms that we relate to prohibition. So while there are elements of good practice currently operating across the UK, when it comes to wider policy and legislation, not much has changed. And while there have been no real significant changes to the UK's drug laws, calls for drug law reform do seem to be gathering momentum from an increasing array of high-profile individuals. And while organisations like Transform and Release have been arguing for drug law reform for many years, along many other NGOs and charities, and alongside a lot of academics, we are seeing these debates become much more pervasive. So in 2019, the Commons Health and Social Care Committee recommended moving from the current criminal justice approach to a more health-based approach, as well as calling for a consultation on decriminalisation. June this year saw Parliament debate the 50th anniversary of the Misuse of Drugs Act, with MPs and peers across the House arguing for reform. And this seems to be true across the UK, as more recently we saw the Scottish Drug Deaths Task Force called for a comprehensive change in its legal response to drugs. And while there are elements, like I said, of good practice that currently operate across the UK, and if Jason joins us, I'm sure he'll tell you about them, the one that he has set up, more needs to be done, as outlined in the recent review published by Dame Carol Black. And while her recommendations acknowledge that investment is needed to improve treatment, employment, housing, and the way that people with addictions are treated in the criminal justice system, it still retains a criminal justice-led approach, which to date has not been effective, illustrating the need to revisit and reform the current system. And that will be the focus of tonight's lecture and its subsequent questions from the audience and answers from our practitioners. Therefore, I would like to hand over to our first speaker, which is Sue McAllister from the Prisons and Probation Ombudsman.
Thanks, Tammy. Thanks for that introduction, and good evening, everybody. I worked in the prison service for 25 years as a governor, as an area manager, and in a number of policy roles. I then worked in the Northern Ireland Prison Service as Director General, leading the service for 4.5 years, where I was leading a root and branch review of the entire prison system following the devolution of justice in Northern Ireland. In every job that I did, the challenge posed by drugs was one of the things we wrestled with. In prisons, drugs are a scourge. Drugs get into prisons despite the most comprehensive strategies designed to stop them. They get into prisons despite the very best efforts of prison officers and prison staff who work tirelessly, searching, gathering intelligence, screening mail, even using some very clever dogs to detect drugs. They get into prison despite some very fancy technology that can see through people, inside people, as well as inside bags, bottles and packed lunches. I was in Leicester prison last Monday and I saw for myself the brand new, very, very swanky body scanner that they're using now to detect drugs coming into the prison. Many governors would, I'm sure, describe drugs as the single biggest problem they face in running safe and decent prisons. And that's before they even start to think about tackling the causes of offending or preparing prisoners for release. Drugs are a real scourge. I don't work in the prison service anymore. Those problems are no longer my problems when I go to work every day. My job now as Prisons and Probation Ombudsman is to investigate deaths in prisons and investigate complaints that come to us from prisoners. But I'm primarily here to talk tonight about the work we do investigating deaths in prisons. And I'm going to speak to you this evening about some of the things that we find where those deaths have involved the misuse of drugs. I haven't got time to go into too much detail, but I want to say something about deaths that involve the misuse of prescription drugs. I want to talk about deaths that involve illicit drugs. And I'll also talk about deaths that we investigate in probation approved premises. So that's where people die after they've been released from prison. I'm going to use a couple of case studies as well to illustrate what I'm saying, because I think, first of all, stories about people are always more important than theory and hypothesis. But also it's important to remember that the cases I'm talking about involve real people, people who died while they were in the care of the state and whose deaths involved drugs. Thank you. First though, what sort of drug-related deaths do we investigate? What do drug-related deaths in prisons and in the probation service look like? Some of the types of deaths that we investigate are overdoses, so intentional and accidental overdoses in prisons and approved premises. We see accidents of people while they're under the influence of drugs. One very dramatic one we investigated in a prison some time ago was where a man sitting on his bed using spice, psychoactive substances, managed to set himself on fire and couldn't reach help in time, couldn't get to press his bell, couldn't put himself out, so actually burned to death while he was under the influence of psychoactive substances. We see self-inflicted deaths of people when they're under the influence of drugs that alter their mood. So we see that decision making by people who decide to take their own life can be influenced, heavily influenced by the misuse of drugs. We also see some self-inflicted deaths where we find that somebody was in debt or being bullied for drugs, and that bullying or that debt led them to be so distraught, so hopeless that they took their own lives. And we also see some unexplained deaths of relatively young men from unexplained heart attacks where there's no history of heart problems, and seizures where we find in our investigations that those deaths are linked to the misuse of drugs. It's impossible to say how many other self-inflicted deaths that we investigate might have a drugs dimension. So sometimes we think that there might be a drugs dimension, but we can't evidence it. And so those deaths are not categorised as drug-related deaths. So there's a hidden number there, despite the all too high number that we do categorise as drug-related. So I want to talk a bit about prescription medication. It won't surprise you to know that a significant number of people in prison are on medication that has been prescribed to them by a doctor. They either have medication prescribed to them in the community and their use of that medication continues when they come into prison, or they find that they develop conditions, or they feel that they need medication that can be prescribed to them by a prison doctor. We investigate deaths where we find that the use of prescription medication has contributed either directly or indirectly to death. And we find, for example, that some prisoners are allowed to have their prescribed medication in possession, and we find that that ought not to have been the case. So they either stockpile medication or they buy other medication to supplement their own medication and die as a result of that. We also find sometimes that prisoners are prescribed the wrong medication for their condition. So we find that when we do our investigation, which is always accompanied by a clinical review, the clinical review finds that particular medication isn't recommended for use by somebody who's going to be on that medication for a long time, for example. So it's not recommended for use in prisons for a long time. We find that sometimes medication is prescribed that doesn't mix well with other medication. And we find very often, I think it's fair to say, that information sharing about prescription medication is poor. There is a belief, sometimes justified, sometimes not justified, that medical confidentiality trumps the effective sharing of important information between clinicians and prison staff. My next slide gives you a case study. So if I have the next slide, please, of a case that we investigated. I'll call this man Mr. M, and we found that he died from a combination of 6 different prescription drugs. All but 2 of the prescription drugs found in his system had been prescribed to him, so 4 had, 2 hadn't. Worryingly, some months before he died, Mr. M had told a prison doctor that he was buying prescription painkillers from other prisoners. That doctor, incredibly, didn't tell prison staff or the substance misuse team what he'd been told by the prisoner, and he continued prescribing pain relief. Our investigation found that one of the drugs being prescribed to Mr. M wasn't advocated for long-term use in prison, and we were concerned that no one ever carried out a medication review just to make sure that Mr. M was on the right drugs, the right amount of those drugs, and that he wasn't suffering any ill effects. So you can see that a number of things went wrong. There were issues around prescribing, there were issues around security, the fact that Mr. M was able to buy prescription medication from somebody else. You can extrapolate from that the somebody else that he was buying drugs from should have taken the drugs themselves, so they weren't taking their medication, and that wasn't identified either. So a number of things went wrong. Next slide, please. Just looking now at the use of illicit drugs, which is what we really think about when we think about drug misuse in prison. We think about, in my day working in prisons, it was cannabis, sometimes class A drugs such as heroin and cocaine. Now, the drug that's most concerning to prison staff undoubtedly is spice, psychoactive substances, what used to be called legal highs. But illicit drugs are undoubtedly in widespread use in prisons, despite, as I said, the best efforts of prison staff to keep them out. In our investigations, we find, of course, that prisons must have a robust drug strategy and a robust drug testing programme in place. And many of you will know that in British prisons, there is a programme of mandatory drug testing where a randomly generated percentage of prisoners are tested every week. Now, that programme has lapsed somewhat during the COVID restrictions, when nothing really is happening in prisons other than the very basic things to keep people alive and safe. But there is a robust drug testing programme, and that needs to underpin the drug strategy that operates in every prison. But what we also find, and one of the things that concerns us, is that sometimes staff aren't vigilant to the signs of drug use, and so they're not able or in a position to take appropriate action when a prisoner is suspected of having taken drugs. So we find when we investigate a death where somebody has died having taken drugs, prison staff sometimes tell us that they had no idea that drugs were being misused, that a prisoner was under the influence of drugs or was buying drugs or using drugs. Now that's a worry, particularly when we also find that prisoners tell us that they were fully aware that somebody was using drugs, that the signs were all there, that it was obvious that somebody was, behaving in a way that indicated that they were misusing drugs. So what prison staff really need to do is to be vigilant to the signs of drug use. They need to share information appropriately with healthcare, with substance misuse teams, and submit intelligence reports so that prison staff have a rich intelligence picture of the misuse of drugs on their wing or in the particular landing that they're responsible for, and can support people when they need that support. So, as I say, we find that sometimes prisoners tell us that a deceased person was using drugs every day, and staff say that they were completely unaware. Now, the key worker programme, the key worker scheme that now operates in every prison, again suspended during the COVID restrictions, means that every prisoner will have a key worker who is responsible for having high quality contact with them, who's responsible for getting to know them, getting to know what their issues are. And we are hopeful that that means that there will be better staff prisoner contact, that it will be more meaningful, and that staff will have the confidence to challenge drug use as well as identify it. So it's not a particularly positive picture at the moment, but we remain optimistic that that may change. Next slide, please. Talking a little bit then about approved premises. Some of you may know approved premises as probation hostels, but we've made a number of recommendations about drug use in approved premises over the years. including we've said that naloxone should be issued to all staff working in approved premises. Naloxone is a drug that can reverse the effects of an overdose of drugs. And we're absolutely delighted that that recommendation has been accepted and that naloxone is now being rolled out to all approved premises across England and Wales so that staff will be able to use it and save lives. But we've also recommended, in a similar way to the recommendations we make in prison, that staff working in approved premises must be able to identify when somebody is misusing drugs, that they must be able to identify when drugs are in their hostel, when drugs are in the approved premises. And we find all too often that that's not the case. And we find that even where the signs are all there that somebody is misusing drugs, not enough action is taken to prevent that and to support the person and to save lives. And this case study illustrates that particularly well, I think. Mr R, as we'll call him, was released on licence to an approved premises. He had a long history of substance misuse, but he had worked very hard in prison and staff had worked very hard with him so that he was alcohol and drug free on release. When Mr R arrived at the approved premises and started to settle in, he raised concerns with the approved premises staff about the level of drug use at the hostel, and he asked if he could move. He wasn't moved and nothing was done. A week later, he was found on his bed covered in vomit. A fortnight later, he appeared to be under the influence of drugs. On both of those occasions, staff monitored him, so they kept an eye on him, but they took no further action. He wasn't moved. No real work was done with him to identify what drugs he was using, where he was getting the drugs from, what support he needed to get clean again. And a few days later, staff found Mr R collapsed in a bathroom and an ambulance was called, and Mr R died in hospital from the toxic effects of psychoactive substances. We find that often staff in approved premises don't do enough to explain to prisoners, to people when they're released, that their tolerance will have reduced significantly, that they can't use in the same way as they used before. And we find that that can have fatal consequences. Just to give you some idea of the number of deaths that we investigate, in 2020-21, so the financial year just finished, we started investigations into 30 what we call other non-natural deaths, most of which were drug-related deaths. Now that was 8 fewer than the previous year, but there were some deaths, or there are some deaths that still await classification, so we think the numbers are likely to be the same. That means that the number of drug-related deaths has remained constant. Now that may seem like good news if the number isn't going up, but what we had hoped was that the suspension of opportunities for drugs to come into prisons, which came with the restricted COVID regime, might have reduced the opportunities for people to misuse drugs and might have reduced the number of deaths. So social visits weren't taking place, prisoners weren't moving between prisoners weren't going out on temporary licence to work every day, which gives them an opportunity to bring drugs back in. But the number of drug-related deaths shows that that wasn't the case. So that really was a disappointment to us. And we know that despite the very restricted regime, prisoners continue to be able to access drugs with relative ease while they're in prison. Tammy started by saying that we were going to talk about what worked well or what worked well. Now, the very nature of my role as Prisons and Probation Ombudsman means we only come into play when things haven't worked well. So unfortunately, I'm not in a position to tell you what does work well. And it's a shame because there is a lot of good work taking place in prison with substance misuse teams, with healthcare staff and with prison officers on landings to support people, help them to come off drugs and help them to stay off. But the nature of our work means that we come in when people have died. So when the very worst outcome has happened, and it is inevitable, that we only find failings, that we concentrate on failings. What we try to do, though, is to look at the impact our work can have. So when we make the recommendations that we make about how staff need to identify the misuse of drugs, how they need to share information more effectively, it's with the hope that our work can have impact and that those recommendations can lead to lasting change, and that as a result of that, lives will be saved and the number of preventable deaths in prison, including drug-related deaths, can be reduced. Could I have the next slide, please? If you want to know more about the work that we do, read our annual report, which we published last Wednesday, so 1 week ago. It's available on our website. If you Google 2020-21 PPO annual report, you'll find it. Look on our website at some of the reports that we publish, some of our fatal incidents investigation reports, but also look at some of the learning lessons bulletins that we publish. We regularly publish bulletins which crystallise the learning from our investigations. So we have published bulletins in the past on drug misuse, we've published bulletins on psychoactive substances, and we've published specific reports on deaths amongst women prisoners, deaths amongst young people. So for those of you who are interested in knowing a bit more, there is plenty out there that you can find to learn more about the work that we do. And follow us on Twitter, and please subscribe to our external stakeholders email list, our mailing list, because if you do that by emailing PPO Comms at the address on this slide, we will send you all of the things that we publish, whether you like it or not. We'll send you our newsletters, our bulletins, and any other publications. Thank you very much. I look forward to hearing what Jason has to say and then to answering some questions from you later on in the evening. Thank you very much.
So, thank you, Sue. So we have got Jason Kew with us from the police, so I am now happy to hand over to Jason, who will talk to us about drugs in the criminal justice system from the perspective of the police. Over to you, Jason.
Thank you very much. Hopefully you can hear me okay and see me okay. And my sincere apologies for being late and all this technical kerfuffle, but I'm really grateful for everyone that just helped me get on, because my old brain, I can't cope with all this tech. But thank you so much. Thank you so much. Firstly, it's a real honour to be speaking before you and with the Scarman Lecture. The pedigree of speakers in the years before me are astounding, and I'm really truly humbled and honoured to be here, and thank you for the invitation. Ultimately, I'm just a cop, okay? I'm just a cop. I think honestly about drugs and policy. I have over 25 years of experience, and drugs has been a constant prevalence throughout each and every one of those years, as has Tammy, your description of drug-related deaths. It's true that the UK has the highest number of drug-related deaths on record. I won't get tired of announcing that stat at the start of every presentation I give, because it's a tragedy and it's absolutely necessary that we get to the bottom of that. So thank you. We often hear taglines, phrases such as a whole system approach or a public health approach, but what does that actually mean? We can say these things, but do we actually mean these things? Are we really truly invested in a whole system approach? And if you look at, I'm not going to open this discussion or this talk around what is wrong with the system. I'm not going to blame stats and stuff, but it's wrong. I'm going to contradict myself slightly here. It's wrong to ask the police to enforce a law which causes unintended harm on the scale of the Misuse of Drugs Act. It's ethically, it's morally incorrect to do so. There are aspects of the Misuse of Drugs Act that are effective still, don't get me wrong. Supply, organised crime, exploitation, harm, that needs to be investigated to protect our communities. But possession of drugs is a health matter. The fact that a law is being used for 50 years to deter people ideologically, to deter people from possession or use of drugs which isn't working, is wrong, and that needs to be reformed and managed completely different. Because at the moment, what we're seeing is that police forces and public health and academics are working together to effectively decriminalise the person, not decriminalise the drug, because obviously the Misuse of Drugs Act still exists. But by decriminalising the person, that person stands a much stronger chance then and there, or later on in life, if problematic use developed, to seek the help that they need or may need. Not all drug use is problematic, and education, therefore, is as powerful as harm reduction as much as that person needs. Yes, the state has a duty of care, as with tobacco, which causes untold millions of deaths, as alcohol, which causes untold millions of deaths and harm, and in fact is the most costly drug of all in society. But the numbers of people that will probably have a glass of wine tonight is astounding. But that's a profit driven market, and one that pays some political parties quite well. We need to move away from that. Any future discussion around cannabis regulation, for instance, there's a significant evidence base that reduces harm. We need to look at that evidence carefully, but it cannot be done in a profit driven ethos. So what am I going to say? So there's lots of evidence around the frailty of the Misuse of Drugs Act. The review, government's own review into the 2017 drug strategy, actually by Brendan Lewis, actually found that there's a lack of robust evidence as to whether capture and punishment actually deters drug use. So the government recognises this back in 2017. Clearly, the very fact, and this quote is going to be cited to Dr. Wojciech Spit, my colleague who co-developed the drug diversion scheme alongside me. He quotes that for those already found in possession of controlled drugs, the Misuse of Drugs Act has failed. That act of deterrence has already failed because they're already in possession of it. So the stats that Tammy mentioned at the beginning of this lecture are compelling. 1.3 million young people aged between 11 15 have consumed a controlled drug. That's 20% of that age group. The 16 to 24-year-old bracket is similar. These are similar stats, and the evidence is contained within the crime survey in England and Wales. It's well documented evidence about the size of the drug market, so we need to act differently. The true way to tackle drugs in society, though, I believe, is through a whole system approach. But that's the community, the public, the police, local authorities, and this team of teams. I was speaking with Stan Gilmore, the VRU director for Thames Valley, earlier today, who summed that up exactly well. The VRUs are something that can initiate and implement change right here, right now. The Thames Valley drug diversion scheme, as Tammy explained, doesn't require an arrest, doesn't require an admission, and it doesn't require an interview. So through a trauma-informed engagement on the street, someone in possession of any substance can be positively engaged and afforded an assessment of their use by an expert, not by a copper. The copper goes in 10 minutes, and we can evidence the effectiveness of a trauma-informed engagement and education and further onward harm reduction in a much more effective way than prohibition or the robotic prosecution could ever do. So we're making success. So there's great evidence from Thames Valley, Durham's checkpoint scheme, West Midlands divert scheme, Avon and Somerset's drugs education programme, and others. This emerging evidence is informing practice and policy now, but it's led by police, it's led by public health, and it's led by academia, where it should be led by ministers and lawmakers. I think what I'm going to say is that the VRUs perform that government leadership. We can depoliticise by working collaboratively with health and academia. We can depoliticise these prickly, hotly debated subjects, such as not only how to deal with someone found in possession of drugs, but also drug consumption rooms and other harm reduction, really effective harm reduction strategies and policies that need to be implemented here in the UK. There is absolutely no reason on earth why a drug consumption room cannot be opened in an area that needs it the most. And the recent events around isotonitazine infiltrating the heroin market absolutely show these in stark reality. This week alone, I've never seen as many drug-related deaths in all of my career. and the links to vulnerability, to re-engaging the most disengaged and marginalised in our communities can only be put right, or can only be done by this leadership within the violence reduction units, within a true whole system approach to enable innovation and to allow these schemes to grow. So to summarise Dame Carol Black's reviews and the main findings, this presents us and policymakers a huge opportunity for that joined up approach, that team of teams, that true partnership approach to develop a truly effective drug policy. We need clear accountability, and again, that partnership and the governance around the violence reduction units, because the innovation and buy-in for stronger ethics, for more consistent leadership throughout the system can only save lives. I'll give you an example. Why does someone who's found in possession of drugs in a local authority housing or private housing even face eviction for that drug use? That system, if someone's developing problematic use and they're using drugs in that environment, then chucking them out onto the street is the last thing that person needs. They need care and support. We need to research as well innovation. This is absolutely key to furthering the evidence base. Thames Valley scheme is ripe for an evaluation, and that's a process already, but the checkpoint scheme in Durham has already been evaluated. There's compelling evidence of what works, and this should inform policy as we speak. But the whole system is bigger than just the law or treatment and outcomes. It's about social capital as well. The role of the third sector, the charity sector, is absolutely crucial in providing not only that social capital of being there at 10 o'clock at night when no one else is, and armed with a naloxone or even a cup of tea. It's that non-judgment. It's that wider support and navigation into employment, into health, and drug consumption rooms can provide that right now. What I saw for myself in Copenhagen, in Vestbro, which is one of Europe's biggest drug consumption rooms, was a gent in his late 30s, early 40s. He was homeless and he was disengaged or not known to any drug services at the time. He came in with a wrap of heroin, spoke to the nurse, handed over, engaged obviously positively, handed over his heroin to be tested there and then. She came back with an analysis which nothing untoward was present, and she asked him where or how he uses. He said he injects into his groin. She saw that he had an open wound, an abscess in his groin. She said, don't go there, scanned him a safe vein, but was able then to start that harm reduction, to start that humanist approach into looking after that individual, treating that person as a human. In that 20 minutes that he was under with the heroin, in that 20 minutes, I saw the most humanist sight I've seen in my life. It was like an A&E, a scene from an A&E triage of support. There was homeless, employment, food, clothing, even a haircut and a chiropodist were available to look after that person. But obviously the wounds that he had on his abscess were the priority, and also re-engaging him into recovery, because recovery is possible, but we need to provide those opportunities. And currently our drug services do the absolute best they can with the resources they have, but it's not enough, and no disrespect to them because they're doing everything they can, but it's the support that this whole system can bring with them. So we absolutely need to support that, and by doing so in partnership with police, health and academia and the community, we can do that together and depoliticise this whole debate around drug policy and create change. And in fact, we're creating change now. So all credit to the work and the ethos, the public health approach ethos of the VIUs, because that's where change is happening right here, right now. Don't get me wrong, the Misuse of Drugs Act needs to be reformed immediately. But in the meantime, the work of the VRUs is a real life example of what works. I can go on much longer than that, Tammy.
Thanks, Jason. We'll stop there. And I can see there's several questions in the chat, so we'll go through those now. So thank you both. So thank you, Sue and Jason. And Jason, I'll let you have a little rest. So I'll pose a question to Sue first, so you can catch your breath and recover from the IT issues. So the first question, Sue, is from Dr. Joss Bray. And it's asked, does Sue and her team look into levels of healthcare staffing in prisons, in particular qualified versus non-qualified staff, and numbers on duty, to see if this is a contributory systemic factor in less than optimal identification and care of people who misuse drugs?
Thanks for that question. When we carry out our investigations and we look at the performance of staff, including healthcare staff, it's very difficult sometimes to make a connection between the numbers of staff, the resources available, and what actually happens on the ground. There obviously is some argument that having fewer staff means that you can't get things done, but I think it's fair to say that when we find failings, it's more often about the failure of individual people to do what they should do than it is about anything systemic. We do find systemic failings, and we do make recommendations that systems should be reviewed. What we stay away from, though, is saying that resources are inadequate. That's a matter for the service in remit, in this case the prison service, and in the case of healthcare for the NHS, because it's not for us to say that more money should be put into healthcare in prisons in the case of the question you ask, because that's not within our remit. So no, we don't. We make recommendations based on what we find and what we can evidence. But I would suggest that if you were to talk to people working in prisons and working in healthcare centres in prisons, obviously they're going to say that with more staff they would be able to do more things. But that tends not to be where we find things have gone wrong.
Thank you, Sue. So I'll move on to a question for Jason. So Jason, we have a question from Pius, and he said that you mentioned the Misuse of Drugs Act is effective at disrupting supply chains and tackling exploitation. Does supply disruption not exacerbate crime, with organised groups competing for the market, taking advantage of gaps in the market created by policing? Yeah,
that's a brilliant question, and I'm so glad it's been asked, actually, because this is the wicked problem, isn't it? I completely advocate forms of regulated markets, as I was mentioning about the evidence base from Canada with the regulated cannabis market. If done so on, there's lots of caveats around this though, because if done so on a health-based only model, one not for profit, there's a potential there that you could outprice some forms of criminality. So with Canada, I believe some of the pricing has been enabled so that it then restricts, I'm trying to get my facts right here, but it restricts the high strength THC cannabis from the young market. So obviously in a regulated market, you know, an under 18 or an under 21-year-old is not going to be able to buy cannabis. So they're going to still have a touch point with criminality. So an organised crime, organised crime will still exist around the drug market, because there's still an available market there with the underage. So the evidence around regulated markets is an interesting one, but it's obviously still being evolved. What I do like, leading on from that, is the model in Massachusetts, where there's the social, I can't remember what it's called now, but the social equity kind of program. So basically the state employing people from prison, so rehabilitative opportunities to readdress and get back into a legal supply market rather than an illicit one. So there's those opportunities. I can't remember what it's called, social equity program or similar. But the Massachusetts model is a really interesting model that we should look at the evidence carefully on. I think you know, some police officers, some of my colleagues will think, God, he's controversial, isn't he? But actually, no, I'm not. It's looking at the evidence about what's working elsewhere and so on. One of the greatest forms of regulation, I guess, is around heroin-assisted treatment. So heroin-assisted treatment or opiate-assisted treatment is in effect a regulated supply. You know, if you're concentrating on the top 10% or the most disengaged from any services, then re-engaging them into the drug of need, and I say heroin being a drug of need here because it's not choice when it's that problematic, then you have to look at the person's needs to stabilise and then promote recovery where those opportunities exist. And there's great evidence here in the UK currently in Cleveland of that exact model. And for crime reduction, and now this linking this back into organised crime and gaps, there's going to be evidence within Cleveland's model. If they've taken out the top 10% and from the criminal illicit market and entered those people into a regulated heroin-assisted treatment pilot, then that's taken the top 10% who can consume up to 30 to 66% of all the illicit heroin away from organised crime. But what's happened in that void? And you know, that's a big chunk of the market that's missing. So yes, there's opportunities and gaps. Just to finish off with that point, the police cannot ignore organised crime. The police are unable to ignore exploitation. The police still have to take action against those who supply and cause harm. That's not going to change. Even in the regulated market, there will still be police activity in those touch points of organised crime and the illicit markets. So that's not going to go away, and that's part of the wicked problem of policing drugs. It's not easy. It's complex at all levels, but I think we can begin to readdress some of the over-policing and the disproportionality and the unintended consequences of the Misuse of Drugs Act through decriminalisation to begin with, and what we're doing now around drug diversion schemes. That's long-winded, and I've tried to encapsulate such a big question within such a small piece of time.
Thank you, Jason. So we'll move on to a question for Sue next. So this question is from Aggie. So thank you, Aggie. And I'll combine them together. So there's two questions. There's two parts to this question, Sue. So is there any correlation between deaths in custody and lack of appropriate interpretation services amongst non-English speaking prisoners? And another question is nationality recorded in the numbers of deaths in custody or probation approved premises? Over to you, Sue.
Thanks, Tammy. In answer to the first part of the question, we have carried out investigations where we found that things haven't been done as well as they should have been because somebody didn't have English as their first language or didn't speak English well enough. So one case, for example, I remember where we found that a reception interview hadn't used an interpreter. So you have to wonder how much the person actually understood about what was being asked of them on their initial reception, and a first night interview, which should be carried out by a prison officer within the first 24 hours, wasn't carried out because a person couldn't speak English and couldn't understand. Now, what's very difficult sometimes to evidence is that caused or contributed to a death. What we would say in our investigation reports is that we found that was a failing. We found that was something that hadn't been done well enough, and we will make a recommendation that in future cases things should be done more appropriately. So interpreters should be used. There is a language line that can be used. But to ask whether there is a correlation between those deaths and the lack of appropriate interpretation service is very difficult for us to say, and if we can't evidence it, we won't say it. We often find things that have gone wrong cannot be seen to have contributed to the death or caused the death, but that doesn't prevent us from saying that things have gone wrong and should have been done better. In terms of your question about the recording of the number of deaths in custody, I think it's important to say, we're often asked about this, it's important to say that the statistics about the numbers of deaths in custody, and by extension the characteristics of those deaths, including nationality, are a matter for the prison service. They're not our statistics, we don't own them. So we're not responsible either for recording or for the integrity of the statistics. We only know what we are told by the Prison and Probation Service. So we only know about the deaths that are officially notified to us. So I don't know whether nationality is recorded. We would usually mention someone's nationality if we are aware of it in the course of our investigation, but we have found that there are data gaps in the way that recording is done, both in our own office and in the Ministry of Justice. So I don't know whether whether deaths are recorded in a way that attributes nationality.
Thank you, Sue. So on to the next question, which is anonymous, and it's for you, Jason. So are the drug-related deaths you've seen this week suspected to be connected to the ISO alert?
Yes, some are. It's difficult to get that fast time analysis from any residue left at a drug-related death. Clearly, toxicology takes a lot longer from a deceased person, but if there's any residue left, we will fast track that and prioritise it. So yes, we have seen ISO present in drug-related deaths across Thames Valley. We are absolutely taking that as a priority, and I'm in the face of the tragedy that we're seeing at the moment. I've been warmed. I hate saying that word because I shouldn't feel anything other than dread, but I think I've been warmed by the response I've seen from Thames Valley and all of the partnership to prioritise what's going on at the moment and treat it as a health emergency. We're seeing unprecedented numbers of drug-related deaths, more so than we've ever seen in recent times, and this is an absolute priority. We really care about people across society who use drugs. This is not just about traditional problematic users. This is across the using group, and this is where we need to destigmatise drug policy in order to reach every corner of society. Drug use is common throughout society, and we need to recognise that in our approach to destigmatise drugs. But naloxone works with ISO, and I would take this opportunity really just to share that if anyone is disengaged from a service or has never seen or entered a drug service who happens to use heroin, or someone who uses heroin, do please get them in front of a drug service, or at least use the online facilities. There's many there are many avenues for information out there, such as Cruise Scotland. I'm going to just wrap up, but it's Cruise Scotland, We Are With You, Cranston, and Humankind, and CGL. They're all the big drug services, inclusion to. They've all got online support, and you can contact them out of hours too. So please, just contact a drug service, get that information, and get to know what naloxone is, because it saves lives.
Thank you, Jason. So another question for Sue from Caitlin. Why do you think that prison staff are not being vigilant enough to combat prisoners' drug use and deaths? And do the staff face any kind of negligence charges?
That's a really good question. We find that staff haven't done what they're meant to do for a number of reasons. And I know this from my own time working in prisons, and it's evident from our investigations. There are huge numbers of staff now who are very new to the prison service. The turnover in recent years has been significant. So when I speak to some governors, they have a significant percentage of their staff with less than 2 years service in. So sometimes you could argue that it's inexperience, that often prisoners have been around for a long time. They know all the tricks about hiding their drug misuse. This is not an easy operating landscape. So it's sometimes very easy for us to go in and investigate and say, you should have identified that, you should have recognised that. So sometimes it's inexperience. Sometimes it can be a lack of training. Sometimes it can just be that they're so rushed off their feet that they haven't got time to do that sort of quality engagement that we all know should happen. But sometimes, being absolutely frank, it's because they haven't been vigilant enough and haven't been caring enough. And we, in those cases, We don't shy away from identifying that further investigation should be done by the governor with a view to considering disciplinary action. We don't do that lightly, but we do it when we think it's justified. We can't recommend disciplinary action, that's outside our remit, but we can recommend that further investigation needs to be done internally by the governor. So there are a number of reasons, and we find that failure to identify signs of drug use can happen at all levels as well. Sometimes it's managers, sometimes it's prison officers, sometimes it's clinicians, sometimes it's nurses. So it's across the board and can be for a number of reasons. But it's important to, I think, distinguish between when somebody is trying their very best and just has got it wrong, and when somebody isn't trying hard enough. And that's where we need to be absolutely clear.
Thank you, Sue. Thank you, Sue. So we have another question from Eric for you, Jason. What is more devastating, the effect of drug uses on individuals, or the underground society filled with crime, i.e. dealing, territorial disputes, corruption, etc.?
Yeah, good question, actually. I think I can just balance this out by saying that I, like most of my colleagues, have investigated drug-related deaths and worked with the family of the bereaved, the bereaved family, and that's devastating to the individual family and the individual's family, but also the local community surrounding that individual. I've also investigated murder, which has equally been as devastating, and drug-related murder has equally been devastating. Kidnaps the same. I've seen firsthand the damage that drugs from supply down to use and drug-related deaths can cause. So it's equal throughout. I think what I'm trying to paint here is that our drug policy needs to be a whole system approach. This is not just about ignoring one aspect of drugs here. This is getting a real grip of it all. It'd be interesting to see the development of the ADA areas, which are live now in several areas across the UK, which takes a very much a whole system of lens of drug possession right through to supply, and that uses again the whole system to tackle. And it'd be good to see the evaluation from those areas. But it's good to see that policing as a whole is taking a much more health-based lens. It's true to say that heroin-assisted treatment as one health-based intervention could achieve much larger impacts on organised crime than any level of enforcement could.
Thank you, Jason. So another question for Sue. It's anonymous. So do you think corruption between prison officers plays a huge part in transporting contraband such as drugs into the prison system, exacerbating drug-related deaths?
I think it's a really good question. I think corruption amongst prison staff doesn't play a huge part in transporting drugs. What we do know is that there is a small number of people working who work and use their position as a prison officer and abuse that position and bring drugs into prisons. And I was speaking to a governor recently who had identified a member of staff doing just that and had taken immediate action to report that to the police and to suspend the person from duty. So it's dealt with immediately, and it's dealt with rigorously. But I do think it is small numbers. I think the majority of staff who work in prisons are good people who want to do a good job, and I think it's a very difficult job, and we shouldn't underestimate how difficult it is. But that nobody wants corrupt prison officers working in prison, least of all prison officers themselves. So often the prison service is very quick to publicise when prison officers have been found guilty and often sent to prison for bringing drugs into prison. What's more of a problem, undoubtedly, is prisoners finding very imaginative ways to bring drugs into prison. So we know, for example, that some people get themselves sent to prison and come into prison fully loaded with drugs, and that's where the WYSI technology that I saw recently comes into play. Sometimes people will try to bring drugs in from being out on a court appearance or being outside working, We know that visitors can be coerced into bringing drugs in. So yes, staff corruption is a problem. It's not a huge problem, and it is dealt with in the most appropriate way, which is that these cases are reported to the police and sometimes, but not always, result in a prosecution. But invariably mean that the member of staff is dismissed from the service and then isn't in a position to abuse that position anymore.
Thank you. Thank you, Sue. So another question for Jason. So once individuals, this is from Sam Perry. So once individuals complete the drug diversion scheme, how do you measure evidence long-term meaningful impact on those individuals to ensure the scheme is actually having a benefit to them and reoffending is reduced?
Yeah, thanks for that. That's a good question. It's a complex one to answer, really, because many of the schemes are quite new. So collecting recidivism data will take some time, obviously, for that long-term question to be, answered fully. But from our earlier evaluations, the recidivism data for diversion schemes or community resolutions is outperforming that of traditional prosecutions. So it's becoming a lot more effective. There's some good learning and evidence from the Turning Point West Midlands Peter Neighbourhood's research on that is really valuable. What we do learn from diversion are, so we measure this very carefully about successful conclusions or outcomes. So they're going to look very different from person to person. So with our pilot in West Berkshire, so the young person's drug diversion scheme, that's currently seeing a 93% completion rate of a 6-week course, and that's outstanding because that we have very few people who disengage from that course, and we want to understand why. So at the end of that course, we want to collect that data. But what we find is that over 50% want to stay on beyond and stay in contact with the drug service. That's really new evidence, actually, that needs to look a lot closer into. So it's not just about drugs education and harm reduction, just about drugs that they receive during that input. They receive input for sexual health, for domestic abuse, for sexual abuse, for gang crime, exploitation, mentoring, knife awareness. There's a whole host of opportunity, if you like, of interventions within that package, and it's sometimes down to young people want help just getting out of an escalating social media feud, and it's that assistance with a trusted adult that they've gained access to whilst on the diversion course. So it's much bigger than just drugs. And also, and I'm drifting slightly from the question, but we've enabled drug diversion in schools. So schools now can, in lieu of exclusions, operate the same scheme that we do and access the same intervention that the police do. And that negates the need for exclusions, and that can only have a long-term beneficial impact on that young person, but to measure that is really complex. So we are, though, working with Professor Alex Stevens, who's leading a bid to the NIHR study, and we hope to answer that question in 3 years' time with a much more proper academic voice than mine. So yeah.
Thank you, Jason. Thank you, Jason. If anyone can help you, Alex can help you. So over to Sue again. So I'm going to collapse the two questions. We've got one from Matt Hopkins and one with no name. So do you think that they're sort of linked? So do you think the rehabilitation system is effectively tackling drug abuse amongst inmates? And considering all of the efforts that have been made to stem the supply of drugs into prisons, how do you think the supply is maintained? Do you think there is much staff involvement?
Sorry, what was the first bit of the question again? Tell me.
The first part, hang on a second, was about supply.
I'll look and I'll find it. Don't worry, I'll find it just so that I can make sure I'm answering the right question. About the rehabilitation.
Yeah. Do you think the rehabilitation system is effectively tackling drug abuse amongst inmates?
Okay, I'm not sure what we mean by the rehabilitation system. I mean, there is an offender management model now that works in prisons, which addresses people's offending behaviour. Having said that, we know that work hasn't been done for the last couple of years because of COVID, or the last 18 months because of COVID restrictions. I think there is some really good work going on with people, particularly around addiction, to help them to get clean while they're in prison. but it's not easy, and there are a number of things that we know impact on rehabilitation. So, for example, we know that having a job when you're released is really important. We know that having settled accommodation is really important. We know that having somebody watching your back, whether it's family, whether it's the church, whether it's a friend. So rehabilitation is really, really complex, and we know that there are increasing numbers of people in prison, and there are fewer staff than there used to be. So you don't. It's quite easy to work out that there is less opportunity sometimes to do that quality work with prisoners that needs to be done. In terms of the second part of the question, this was about what needs to be done. I can't remember what the next part of the question is. Can you remember, Tammy?
So, considering all of the efforts that have been made to stem the supply of drugs into prisons, how do you think the supply is maintained? Do you think there is much staff involvement?
Okay, yeah, it's a really good question. What we know is that drugs in prison is not just a scourge, it's really big business. So in many prisons, this is organised crime at play. So this is not just individuals bringing in a little bit of stuff secreted internally. This is organised criminals who are working in prisons and outside, because there is a lot of money to be made in bringing drugs into prisons. So we know that business that's operating probably has been made more difficult as a result of the efforts that have been made, the work that's going on to stem the supply of drugs. So it's more difficult if there are X-ray scanners. It's more difficult if there are more drug dogs. It's more difficult if there is better front-end searching in prisons, but it's not impossible. So, you know, people are being paid to bring drugs into prison, to either get themselves sent to prison deliberately to bring drugs in, or to bring drugs when they have the opportunity. Their families are being coerced into bringing drugs in. Prison staff, in some cases, are being coerced into, corrupted into bringing drugs in. So I think what we have to realise is that there is increasing involvement of organised crime in drugs in prison, because it's big business. It's not going to go away, and it is like trying to push back the tide in some prisons, trying to stem the supply of drugs into prison. So we welcome all of the things that we see, because obviously it impacts on safety and it impacts on the number of deaths, but we don't underestimate the scale of the challenge and how difficult it is.
Thank you, Sue. So we've only got 5 minutes left, and there's still a lot of questions that have gone unanswered, but I'm going to draw it to a close to ensure that we finish on time, as a good chair should. So thank you ever so much to Jason and Sue, and to everyone that asked questions. I'm sorry we didn't get to all of them. I think tonight's lecture has highlighted the need for a reform of the current drug laws, and whatever format this takes, it needs to be based in evidence. What is clear is the current system is not working and is actually causing more harm than many of the drugs themselves, and that, as Jason pointed out, it is morally wrong to ask people to enforce this law and abide by this law, and many aren't, as some of the statistics that Jason mentioned earlier. So I'll turn to another for the final word and the final thought, I think, for today. So McCoy and Rutter said in their book, Drug War Heresies, a drug policy that causes more harm than it mitigates is difficult to justify. And I think that really rings true when we talk about the current system that we have in place. So I hope tonight has given you something to think about. So thank you all again for attending. Thank you to our two speakers and to everyone behind the scenes, particularly Thomas Everly and Scott Skidmore, that made it all possible and resolved our technical issues and saved the day. And I hope you all enjoyed the discussion. And as I said, thank you ever so much for the insightful questions. So good night, everybody, and thank you for attending.